If a patient calls your office because he had trauma to their eye, usually we're thinking, okay, it's probably going to be a corneal abrasion. But what if it's one of the other 10 things that could happen from trauma? Check out this awesome clip that covers a few trauma examples.
You've asked to do a little bit of rapid fire. Okay, I'm going to show you a picture and you say yes or no, could that come from trauma? In the first one, we have this gonio image. Could this come from trauma? And the answer is yes. Normally in a grade 4 angle, the ciliary body is going to be about the size of the trabecular meshwork. So you have a giant area of ciliary body here. So this is angle recession. All right, on to the next one. Here you go. Hyphema. Can you get hyphema with blunt trauma? Yes, absolutely. What do you do in this case, or how do you treat and manage these patients? Well, you do not want the hyphema to stain the cornea, so these patients will need to sleep with their head elevated. You want to avoid NSAIDs if this is an older patient, unless they need the NSAIDs to survive, okay? Kind of a general rule is if they need that medication to live, we just deal with it. My first question is there IOP increase? Because red blood cells bigger than white blood cells. In these patients, you can have an increase in IOP. Usually I'm going to cycloplege this patient to make sure that iris isn't flopping around and just letting a bunch of blood come out. And we'll put them on some steroids, for example, pred 4 times a day. These patients can rebleed, meaning that they start bleeding more, and this hyphema will get worse. Okay, so I'd say see them back in about 4 days, in that 3 to 5 day window to make sure the hyphema is not getting worse, and then you're watching their IOP. As far as like angle recession, right? Make sure you don't do gonio at this visit, because you don't want them to bleed. They're still like in the fragile state here. You can do gonio. If somebody comes in like this, do gonio at like 1 month or 2 month or 3 month to see what the angle looks like. All right, next case here. Can you get this with blunt trauma? If you're thinking commotio retinae, yes, you can get that with trauma. However, this is not that. This is an artery occlusion. Okay, artery occlusion is a stroke to the eye. You send that patient to the emergency room because they could have a stroke to their breathing center. How about this one? Yeah, this is commotio. Okay, this is commotio retinae, right, which is edema of the retina, but specifically what layer? It's photoreceptor. Edema is of the photoreceptors. So this is commotio retinae. If it happened over here at the macula, what's it called if you get commotio at the macula? That's called Berlin's edema. Both of these you're just going to monitor. So if somebody came in with commotio, probably see them back in a month, unless they were symptomatic, right? Telling them RD precautions, any increase in flashes and floaters. All right, how about this? Could this come from blunt trauma? This is a retinal detachment, like you can see the wavy. It's not choroidals. You can't see the retinal break here, so you'd want to find the retinal break here. And if not, you do B-scan to see if there's something going on underneath, like a melanoma or osteoma. But in this case here, this patient ended up having a rhegmatogenous retinal detachment from a horseshoe tear. Could that come from trauma? Yes. How about here? You got a retinal attachment, but this is specifically, you'll see the fibrosis there, fibrosis there, fibrosis there. Tractional retinal detachment. This is coming from diabetes. Tractional retinal attachment. Does tractional retinal detachment come from trauma? No. How about here? Can you get an exudative retinal detachment from trauma? The answer is yes. How could you get it? Well, what could happen is you could get something that looks like this immediately after the trauma, which is going to be choroidal rupture. And then you can get a CNVM from that choroidal rupture because now there has been a break in Brooks. Hey, look, with blunt trauma, can you get any kind of corneal problem? Yes, you could get an abrasion. Okay. In the anterior chamber, blunt trauma, what could it cause? Well, it could cause either a uveitis or it could cause hyphema. And if you hit the retina / eye hard enough, boom, that optic nerve could get sliced. So you could get a traumatic optic neuropathy. So I like to call this the Texas trauma. When somebody comes in with trauma, this is how I'm approaching their eye. When I'm looking at them, okay, do I have an abrasion? Okay, no, do I have uveitis, hyphema? I'm literally going down this list as I'm looking.
Hey guys, I hope you enjoyed the video. This was just a sneak peek. For more awesome clinic content like this, please subscribe to KMK's new clinic PowerUp course. This is the #1 requested course by practicing optometrists. We have an extensive library, 37 hours, 100 videos to help you dominate any condition that ends up in your chair. Efficient and practical, this course is our best work yet. You can sign up by clicking on the link in the description. I'll see you on the next video.